So Sir Peter Piot, was the professor of global health and former director of the London School of Hygiene and Tropical Medicine. He also served as special advisor to President von der Leyen on European and global health security to the EC. He's only just stopped that job, that position right now, but he has a very, I won't repeat too much of it because his background is very well known to most of you. He was one of the two founders discovered the Ebola virus in the Congo some decades ago, but also made perhaps as large or even larger contribution to HIV. In the days that he worked in the Congo in the early 1980s, at that time globally, people thought that the HIV pandemic was a pandemic largely affecting gay male men. But he and others wrote a series of seminal papers in the early 1980s about it really being a pandemic of heterosexual young people, especially affecting women. And many, many other things as well. His work initially in the Congo, then later in Uganda, has been seminal in the HIV sphere. I think it was 1995, he was appointed the Executive Director of UNAIDS and Under Secretary General of the United Nations. Just a brief moment of background. At the time, in the mid-1990s, I think the WHO realized that as the WHO, just HIV was such an enormous thing, it was almost overwhelming the WHO, and they needed to create a separate organization, which was known then as UNAIDS, and Peter was the founding executive director. I first really got to know Peter indirectly, and Nairi indirectly, when Nairi Woods here was commissioned to provide a blueprint as to how anybody was going to carry on the work of Peter when he stood down as the executive director. And we spent a whole week trying to think about what was the next step. Anyway, I won't go on about that in any detail, but Peter has written over 500 publications, written many books, and the book in particular, No Time to Lose, is a very interesting story of work he did, especially in Ebola many years back, and I'd very much recommend it. It's very much available online or any good bookshop. So without any further ado, Peter, we very much look forward to hearing you. Peter can talk for about 20, 25 minutes, and then hopefully we'll have a really rich discussion. Peter.
Yeah, oh, that's a good idea.
You want your water?
Yes, put it there. Yeah, no, here it's going to fall. Thank you. Thank you so much, Alan, and great to be back at the Blavatnik School. I think this is my third or fourth time that I speak here. There were seminars at the very early days when there weren't that many people here, but then since COVID I haven't made it to this building. Yeah, Alan, thanks for the invitation. That's now that you're here, I think we maybe have more interactions. And I spent the whole day at the Ellison's Institute for Technology and with Sir John Bell, and that was also a very inspiring day, I must say. I think we need a lot of more disruption in Europe at many fields, in academia, in global health, in whatever, and it's perhaps ironic that you need American money to do that in Europe, but it's, yeah, and so that's, and it's great that it's based here. So what I thought doing was give a bit of perspective. Because of my age, I'm asked to give talks about where are we coming from and where are we going. But it's really, I think we're in a critical phase of when you think of global health, a term which did not exist when I started working in global health. It's a term that emerged around the millennium, around 2000. When you Google, ChatGPT, you can't find it before. They just have done global in a sentence and health somewhere, but not global health. And it's a term and a kind of a movement that emerged really out of the HIV response. And that really put health in low, middle-income countries or the global south or whatever, although usually Australians object to that term, that made it to the top agenda. Since we're at the Blavatnik school, I became from like a more like someone who's a clinician and then an academic or working in NGOs and in the field, someone who got more and more into policy and learned it the hard way. And that was mostly through my work on HIV and when I was in UNAIDS. And but also it required that I wish I had some more, be better prepared for it, because I learned that whatever you do in health, it's political, frankly. And so it's not just policy, but also political. And that's why the school is so important here. And that's not, of course, not only in health. And we're at such a pivotal moment again, where in global health, there are lots of changes. And there's some acute, I mean, among other things, as a result of a change in the geopolitical environment, a change in the American political environment, the wars and so on, that and the demographic changes that we are going through in the world, that we really have to take a cold and hard look. What is going on? What are the priorities? And what can we do? What's the agenda? So we're going into what I sometimes call global health 2.0, maybe 3.0, but and that's what I want to talk about it. And first of all, I would like to say that when you look at global health 1.0, and that came out of like originally tropical medicine, international health, and so on, and it became really more of a global initiative. That when you compare hard health outcomes, like as documented in the global burden of disease, exercise that comes out about every year, in the Lancet always, then progress has been incredible, with the dip during the COVID epidemic. But for many, health issues for poorer populations in the world, there's been enormous progress. Child mortality, under 5 mortality, since 2000, has been halved. Also look at HIV. I mean, when I was, in UNAIDS and around the millennium, more than 2 million people died every year. Now, I was going to say only, but that's not the right word, but there are 650,000. So all progress, and I can go on. There are areas where it's going with ups and downs. Malaria, great progress, and then it comes up again. TB, not so great, and so on. So there has been really a lot of progress, and sometimes thanks to innovation. Like, let's not forget that for HIV, for example, when I was still a real doctor, every single of my patients died because there was no treatment. It's only in 1996, so that's now 30 years ago nearly, that you could treat HIV. And that was the result of innovation. Treatment was discovered. Just as we had with COVID a vaccine, but that went much faster. But often was the issue of access that was a problem. But so there's been really a movement, increasing funding, and lots of academic groups here at Oxford, building on a rich, history and tropical medicine. I'm happy to see Kevin here in the audience, and it's been larger. So, and it was no longer often, let's say, only clinical or public health experts, but it was widened. But now we are, I think it's becoming, in a sense, more complicated and more complex. And one of my messages would be of this is that let's not complicate things that are simple or simplify things that are complicated. It's one of my favorite quotes from, you don't know either, Arundhati Roy is one of my favorite authors in India, and in her novel, The End of Imagination, this one of my favorite quotes is about the meaning of life, and that says, what is the meaning of life? And it's to live while you're alive and only die when you're dead. But that's not the subject of this topic, but it's also about not complicating things. But here we have complicated issues. And let me just mention three massive historical trends that are going to fundamentally shift the foundations for global health, and for not to mention every other sector I can think of. Of course, and you know it all, climate change, and I'm not going to elaborate too much about it, but 2024, so last month, that was the hottest year on record, and was the first calendar year to pass the symbolic threshold of warming more than 1.5 degrees. And we, for those who follow it, and when you look at what's going on in LA, you know, in Los Angeles and so on, it's not. I mean, the reason has to do with climate change. But and again, I won't change, but it's going to be heavily affected, indirectly and directly. Perhaps more indirectly, with will be massive migration shifts, nutritional. I mean, food security is at risk. In addition to the fact that extreme heat and weather will make some of the worst affected places unlivable. So that's something that, I mean, we really, whatever we do, it has to be on our radar screen, and we have to include it. The second massive historical trend is, I would say, is the rise of the digital transformation. It started with a mobile phone. Who would have thought when you mentioned Ebola, I was working in what was then called Zaire, now the Democratic Republic of Congo, in the late 70s, or the 70s, a long time ago. And communication, there was none. I mean, there was now and then we could make a phone call. So, but in the end, but now when you go there, there's the average phone ownership of mobile phone, even in sub-Saharan Africa, is more than one per person, even among very poor populations. And so, and there's still no landlines. There's been leapfrogging. So this digital communication, mobile phone, then we had the internet, you know, then social media, and now AI, artificial intelligence. And they're truly game-changing general purpose technology that may come up. I just finished a book by, you know, this Israeli author Harari, you know, a Nexus. He is the author also of some other books. I mean, in 700 pages, he could have said that in 100, I think, but it was very good for if you're in history. His thesis is that how communication and information has been a driver of development of democracy, but at the moment, the way it's going could mean the end of democracy. And he gives example how it started with Mussolini and Hitler and so on, so that who were using for the first time for these days sophisticated communication techniques, and then they've been, you know, gotten how to say more and more sophisticated, and now with social media, that you can really, that the power is concentrated in those who are controlling communication. And it's probably for someone else to talk about that here at the Blavatnik School. But it's exciting to imagine the new interventions and new knowledge that AI will make possible. And today, like at the Ellison Institute of Technology, we had some really exciting discussions about it. And there's a brilliant book that I could recommend by Mustafa Suleyman, The Coming Wave. He's one of the founders of DeepMind. And he's, of course, you know, a big supporter of AI, but also he, you know, he said it I'll quote here, AI will sweep everything in its path, leaving the world remade and reborn. It will be the greatest force amplifier in history. But he said also, let's not forget, it could enable a redistribution of power on a historic scale. It could be redistributing it to the people or in the hands of only a few. And so he talks about the harms and not only about what it could bring. But our job is to harness AI and to see how can it best be used. And it could be like the mobile phone in very poor environments. It could really help to eliminate the need for middlemen, or middle persons, whatever, like doctors and so on. I think when you look at the performance of AI in terms of diagnostics and all that, it's often superior, certainly in imaging. Eliminating the need for nurses and carers, I don't see that happen. It's maybe ironic. But again, it was really, I think, this digital transformation is a huge opportunity and is part of life now. Last month I was in Senegal, in Dakar, and I'll tell a bit about it more why I was there. But I also witnessed firsthand some of the exciting ways that AI technology can be leveraged to build a more inclusive health ecosystem. And it was another Mustafa, but the first name of Mustafa Cissé, who used to work at Google in AI and went back to Senegal and is now using his AI skills to improve access to medicines, payment, and so on. And that for me was, again, an example of where you can leapfrog, and we can use that. So, and I'm not an expert in this, but I would say that it's something that we probably in global health, we've not yet embraced enough. You can be saying, we don't want to deal with it, and it's a disaster or a threat for democracy and so on, but we have to make the best out of it. And then a third big, a massive historical trend we need to account for is a huge demographic and epidemiologic shift, and all over the world. And for a very long time, our thinking global health was about dealing with children under 5 and their mothers, and with good results, and even maternal mortality went down, although not enough. But we now have the oldest population in history of the world. And that's a success story. We live longer. Fantastic. And we've added many years to our lives, including in this country, but in about every single country, although in the US, for example, it's been going down the last few years and as a result of COVID, but in most countries gone up. But we failed to add life to our years in many cases. So when you look at the discrepancy between chronological age and healthy age is, the health age is pretty flat while we're living longer and longer. And that has many, many implications. And when we see, particularly, we see that in Asia, in Europe, and Latin America, but I think we'll see it also increasingly in Africa, certainly already in Eastern and Southern Africa, is that we see longer life and fertility rates or reproduction rates that are below reproduction, so below 2.2 per woman. And so this means these demographic changes, and I'll come back to the positive aspects of it, mean that, for example, morbidity patterns are also changing. Infectious disease will always be there in terms of epidemics will always come there because there's zoonosis and so on. And we can bring some under control, and but think of polio, where for many years we've been trying and hoping for elimination. We're not there yet. But there is a huge rise in non-communicable diseases, from cardiovascular diseases. I'm part of a Lancet commission, co-chaired with Chris Murray from the Institute for Health Metrics and Evaluation in Seattle, University of Washington, and trying to estimate what are the health threats for the rest of the century. It's quite brave to go and to look ahead 75 years. But every single scenario, diabetes comes up as like number one of specific diseases. And there's, of course, cardiovascular disease. Mental health, issues also rising in a big way. Although some of that is because they're now finally recognized. They were so stigmatized that they were not dealt with. But so we see a huge acceleration of these non-communicable diseases. And what we see in some of the African countries, sub-Saharan African countries, that we have a double epidemic. We still see a heavy burden of infectious diseases, but at the same time, we see this rise in diabetes and so on, obesity. When you think of that, the rate of obesity in South African women is now the same level as for women in the US. But in the US, it built up gradually. In South Africa, it was, despite the AIDS epidemic, which doesn't make you fat, having HIV, that, happened in a few decades. So this is a very big change. And so the burden caused by these chronic conditions increased really at every year is going up. So how do we evolve then? And I didn't share these facts and figures just to bring down the mood. It's the beginning of the year. And I'm always more interested in action and in solutions. So let's talk about what we can do. And what do these massive trends really mean for us? First, let me stress one more time that there's still a gigantic unfinished agenda, whether it's malaria, HIV, TB, women are still dying while giving birth, and so on. So we can't really neglect that and stop that. So that has to continue. And some of it is boring, it's more of the same. And some will be helped by innovation, new vaccines, treatments, and so on. And in my own field, like HIV, the Science magazine declared the finding that with 2 injections a year with lenacapavir, an antiretroviral drug, you can prevent 100% of infections in women. And that's come as close to a vaccine as we have at the moment for HIV. And it's also, what's interesting and very important, it protects women. Because up to now, women didn't really have anything except the goodwill of men, which is sometimes a real big problem. So we need to, we can't stop that. But we need to get much better in addressing cancer, mental health, hypertension, diabetes, and so on. But when you look at the funding streams, there's a total, difference between, 34 billion for infectious diseases and barely 1 billion for non-communicable diseases in terms of international funding. Third point is that we must really get serious about what I call healthy longevity. I need to declare, of course, conflict of interest. I'm 75, and but instead of talking about aging, which I find stigmatizing, since we're in an academic environment, we are easily stigmatized. So I can say that, and looking at, it's a term I learned in Singapore, healthy longevity. Singapore has one of the oldest populations in the world. They're competing with Japan for who is the life expectancy, and from a, let's say, stigmatizing and negative thing, aging and the dependency ratio and so on, we say, look, people live longer, it's a fact. Let's make sure that live also healthier for a longer time. You are not rejected by society. Even if in France now they want to reduce the pension age still to about 60. What is the, how to turn this into a positive experience for individuals and for society, which will also be necessary from an economic perspective, the workforce and so that we need. So we must also invent and onboard new AI-powered solutions and so on. So I think that there are lots I could go on and on. So that's about the what. But one of the things I've learned in life is that the how is as important as the what, if not more important sometimes, how we do things. And that's not very simple. And I envisioned 3 changes there where the how is starting to work and to be different. One is I would say, what I would call regional manufacturing of health tools. One of the lessons, of course, of the COVID epidemic was inequality in access to vaccines. And there's a lot of effort going into a pandemic treaty. And now I may shock some people. I've been always pretty skeptical about it because it's something I started understanding when Prime Minister Modi, at some point in India, banned the export of vaccines. I was very upset because I was involved in, an initiative to make sure that that vaccines would go to low-income countries, and we had counted on on India as the pharmacy of the world to produce vaccines. And there, the Prime Minister said, "Stop export." I was really upset, but I always try to think, what would I have done myself? Something I've learned. And then I said, probably I would have taken the same decision. Modi is elected by Indians, not by Africans or others. And he's expected to take care of the best for his own people. And I was thinking that will always be the case. Since you're here in political science and so, I'm more in the school of realpolitikers and so on. And so I said, we need to find other solutions. A treaty is not going to change that because the next crisis, whoever is in charge will try to do the best for their own country. And maybe if something is left, then we can give it to others. So we need to find alternatives. And one is that we need to get serious about manufacturing of essential medicines, essential vaccines, products, also even face masks and so on, where the problems can come, and that you don't depend on the goodwill of others. And that's why I've become very passionate about this vaccine manufacturing and others in Africa. Also, because the time is ripe to do that. The technology has been, the biotech and so on, you can now, it's been, I'm not saying miniaturized, it's like in IT, but there are technologies now, there's more engineering than anything else, that allows you to set up vaccine manufacturing that is a bit less complex than we have. So this is something that I think could be a silver lining of the epidemic. Also, because for the first time in sub-Saharan Africa was not waiting for goodwill from the global north. And that's because for the first time, the African Union, so the political body, together with Africa Centers for Disease Control, which was established after the 2014 Ebola epidemic in West Africa, they were negotiating directly with companies, they were taking the lead and so on, and I was quite involved in that. And I think that was, for me, it's absolutely a qualitative change, and which I think continues now. And that's a very positive one. So that's why regional manufacturing is so important. And when I mentioned Senegal, I was in Dakar in December, a month ago, where the president, and the new, very young president of Senegal, opened, the 2 buildings, one to manufacture yellow fever vaccine, and that's going to happen in a few months' time, and the other one for other vaccines, which will take a bit longer. And I was proud that I was involved in mobilizing 1.1 billion euro from the European Commission to support investments in regional manufacturing, and particularly for CapEx, so for investments that are difficult to get money for and then to de-risk, because these vaccine manufacturers will have to compete with others, for sustainability. And that's happened in Senegal, in Rwanda, in South Africa, in Ghana they're trying, also in Morocco. I think this is a very positive development. And the second point is that in contrast to when I was very young, When I got involved in Ebola, I had zero experience in outbreak investigation. I'd never been to Africa, and yet, because there were no other volunteers, it was the chance of my life. I could go and investigate that. Today, I was then working in Antwerp, and we were the first ones to isolate the Ebola virus, and that was brought by a pilot from Sabina, the airline doesn't exist anymore, Kinshasa. And that was because in these days, there was no laboratory in then Zaire that could isolate a virus. And PCR and the current diagnostic for didn't even exist. And today, they can do sequencing. They have, when there's a new Ebola outbreak, they can immediately see whether there is what kind of lineage it is, and so whether there are new contact tracing and all that. So that's very encouraging. I'm saying that because today we have centers of excellence all over the world. Some of them are a result, certainly in Asia, as a result of the rapid development and the innovation that we see in Asian countries, be it China, India, we have Singapore, just name it. And in Africa, partly also, but partly because of major investments. All this, money that has been going into human resources, PhDs and so on, it really has led to a very strong, centers of excellence. They still are struggling because of the environment and the fact that for their survival, they often depend on money coming from elsewhere. But that's something that is a big change. And that means also that the center of decision-making is shifting also. Who decides what we're going to do? And then thirdly is this, I would say, and I mentioned already one of what I thought was silver lining of the COVID epidemic, the bigger importance of regions, a more regional approach to global health rather than a global one. It brings the issues closer to people. You see it in Africa, we've seen it in Latin America, in the Caribbean, in Asia, of course. Including that the fact that means for me that there's an urgent need for reform of the global institutions within the UN, the Global Fund, Gavi, just name it. And frankly, I think they should also move out of, no longer be based in Geneva or New York and so on, and go where the issues are. And a few months ago, I gave a talk and said there's a need for mergers and acquisitions in the multilateral system. And that will become acute because money for multilateral funding, for global health funding, international, is going down. In Europe, because of the war in Ukraine, more money to defense. Also in some countries where you have extreme right-wing parties in power, and they're often cut in international development, or in the US we see a decline most probably. So we have to see what the best would make. So this is some of the developments I said, and that means that the whole dynamics in global health, and maybe we need another term, are changing. And I think they're moving more and more into more equal partnerships, and I think is a very, very, development. But how to do it, we have to see. But the train is out of the station. But above all, what I'm concerned about is we need more enlightened and forward-looking leadership and proper funding. So including in the countries that are most concerned. And as I wrote in another book that I wrote in AIDS Between Science and Politics, because that's what I constantly was moving between these two, and I said, science does little good when it operates independently of politics and economics. And politics is worthless if it rejects scientific evidence and respect for human rights. And we are entering a phase in an area in many countries where this is at high risk. And that's where I think people who are, your Blavatniks and I don't know how you call yourself, but where it's so important that we invest not only in the science and the innovation, but also in strong policy and political connections. So I'll stop here, and I'm happy to, continue. Thank you.
Thank you. Do you want to sit down?
Yes.
We've actually got, I think, about 100 people online, so there are also questions. But perhaps we can start with questions. Perhaps I could just ask you, just briefly, we could spend the rest of the time talking about climate. But obviously, the political issues of trying to, any thoughts about dealing with governments who really aren't facing, not just Trump, some of the realities, and what kind of ways one might think of persuading them?
Yeah, that's we could spend a lot of time on it, but I think that we're in an academic institution, one of the top in the world. I think continuing to confront societies with the evidence, but doing it in a way that we communicate and that we forget about our acronyms, we forget about our infights and so on, because that was one of the issues during COVID. On the one hand, of course, I'm for academic freedom and everybody should, but if we, as a result, confuse people and that trust is collapsing, you can say these scientists, they don't know what they're talking about, they don't disagree. So that is a dilemma as as scientists. But I think that's one thing. But also, I would say, this is where international organizations important. And I personally have been very disappointed that the COVID epidemic, the biggest epidemic since the Spanish flu, did not give rise to a special session of the UN General Assembly, Security Council. We brought all that HIV to it and in Ebola, but then it didn't. So there was actually, I would say, a gap in leadership. And sometimes because of vested interest and not. And then create brilliant coalition. There is a book, one of my favorite is a book of Adam Hochschmidt, and it's about Bury the Chains. And it's a book about the movement for the abolition of slavery in this country. And he also wrote a book about King Leopold's ghost, since I'm from Belgium. This is, about the Belgian colonization. And he describes how at the end of the 18th century, early 19th century, this was a real movement to abolish slavery, and it was like a very broad one. It was and the person who told me to read that book was Zaki Ahmad, who was an AIDS activist in South Africa, and who was a person living with HIV. And why am I mentioning that? Because it showed that you can only really, unless you have the Fifth Fleet and a revolution and an army, it's through building broad coalitions. And if you take at the time in South Africa, since Alan, your home, your native country, that at some point President Mbeki didn't believe that HIV exists, held up access to antiretroviral therapy, which really, was responsible for the deaths of hundreds of thousands of people. And there was if you would come from the moon and you would say, what brings together COSATU, these are the trade unions, the Chamber of Mines, they fight all the time, but the Anglican Church, some academics and the AIDS activists and so on, they disagree on everything, but they had agreed we need to bring antiretroviral therapy to save our country. And so I think we need to think beyond our, our comfort zone, which has been through social media. We're getting more and more into cocoons and sounding boards and only talk to people who think exactly like we do. We need to get out of that, because otherwise the people who are, let's say, don't believe in science, think that the earth is flat and that vaccines are killing people, etc., not to mention other political issues, they will control us. And yet I see that there is this atomization or whatever. We're all in this smaller and smaller type of identity groups, and we will never succeed in bringing, what we believe in on the agenda. So make these brilliant coalitions, which led to the abolition of slavery, led to saving people from dying from HIV, and there are many examples. This goes against the political visions of some, because you have to be pure, certainly if you're in academia, but in real life you need a broad coalition. Sorry to be long, but it's something that I thought a lot about it, and it's going to be very relevant in today's context.
Thanks, a very good message for us. Omnia, and then us.
Yes, thank you so much thank you so much for your presentation. I'm Omnia Al-Omrani and I work on climate change and health. My question is about the reform of financial institutions, because it was adopted last year in the Pact of the Future, or suggested. How can we drive this reform to meet the urgency of the impacts, especially with funding, for example, for climate change and global health is siloed, is slow, and now with the geopolitical tension, it is difficult for financial institutions to respond. So how can we drive this reform?
Yeah, it's a very, very important question, because I think without that reform, it'll be very difficult to have the necessary, firepower, financial, to have these, to have real impact. And climate change definitely is something that requires global cooperation and investments. And there are several types of reform that are necessary. Some may be beneficial for this agenda, and some not. Like when you look at the whole multilateral system, and including the development banks and so on, were created out of World War II. And when you look just in the UN, the permanent members of the Security Council, that reflects 1945. The fact that a country like India, 1.4 billion people, is not even in there. And the same thing is true in the World Bank, to a lesser extent in the regional development banks, because I think we need to also look, when you think of Sub-Saharan Africa, you have the African Development Bank, and the Islamic Development Bank is very important also, but there are others. But this may or may not lead to better dealing with climate change. Secondly is I would say, the way decisions are being made in terms of what is good for countries is a kind of a problem. But here again, we have sometimes dilemmas. Many countries are struggling with acute debt, crisis of financial space, fiscal space is not there, etc. And then we come and tell them, you should deal with what they see as long term. One example that I was confronted with a few years ago is that Senegal, but also a few other countries in West Africa, for the first time, they found gas and oil. And I thought, okay, great, we're going to finally be able to offer electricity to everybody and develop and so on. But the international banks and so on, they will no longer lend money for fossil fuels. And so I was in a debate, and some president said, so you're in Europe, you ruined the world, you screwed up the climate, and you became rich because, and with the fossil fuels, and now you're telling us we're not, you want to keep us poor. And I honestly didn't know what to respond. And Mary Robinson, the previous president of Ireland, she founded an NGO called Climate Justice. And that is, it's a very difficult issue, but we need to tackle it. And it's not going to be solved by a fund, a climate fund or so. I mean, fund is important, no doubt about that. But we cannot ignore the fact that there are opportunities for some of the poorest countries in the world because they found these fossil fuels. And maybe I would say things that people don't like, but that, so do we tell them just don't touch it and remain poor? And because we don't give them alternatives. We could say, and the development banks could say, a certain percentage of the funding should go to renewable energy, because many of them have plenty of sun, in contrast to where we are here, so, and wind and so on. So there could be, yeah, but there is a, I'm a bit disappointed that, not a bit, but disappointed, that discussion, debate about reform of these institutions is not higher up on the agenda. And this is where I have a bit of a secret hope that probably an upcoming crisis, because of the possibly a decrease in funding, international funding from the US and also from Europe, that will force people to do this, I mean, reforms and to finally take it on. Sometimes, otherwise a crisis, if a crisis doesn't lead to change and to improvement, it's actually unethical if we don't do that. So that's a bit of my hope, but I wouldn't count on it. But that means this leadership is needed. Sorry. Yeah.
Let me just take one, just a little bit of alternate. We'll come back to just one online. So we've got a big online audience, and this is from Professor Michael Kachatrian, who's a professor of health law in Armenia. And he says, thank you for arranging this. I have a question. What institutional reforms at the global level are discussed or undertaken to make the global health system more responsive to upcoming health threats?
I don't think there's much going on discussion. The multilateral, the big funds will fund, so, and now WHO, so their main concern is replenishment. Will we get the money? And I think there is a beginning. The Global Fund at its last board meeting in Malawi in November, I think it was December, made some decisions of changing focus, and so will invest mostly in the low-income countries, etc. But a fundamental discussion about, as I said, there should be efficiency gains. I think they should move their staff. There should be, the decision making should be far more in the hands of their what they call still recipients. All that is not so happening, and but this is where I'm looking at Asia and Latin America, because there's a longer tradition, of taking things in their own hands. But I'm afraid I don't have much to say on that.
Okay. I think we had one. It was Nick. Sorry, go ahead. Introduce yourself.
Thank you. So I'm a clinician who left clinical practice to pursue or to champion the digital transformation that you mentioned, and now I'm here at the PSG studying public policy. So my question concerns one of the side effects of this digital transformation of all our lives, which is what you mentioned, the propagation of misinformation and disinformation, particularly via social media. So my question is, how should we evolve, particularly us as clinicians or scientists or academics, in the way in which we communicate with people? Because we can point to the social media companies to say, do something, but maybe as training institutions, which you did lead a training institution, how should we then train future clinicians and scientists to be able to communicate with an audience that won't pay attention, that won't pick up a journal, that won't read the New York Times, that won't respect the number of letters that follow your surname? So how should we evolve in terms of being able to communicate? Thank you.
Yeah, thank you for a very important question. And the good news is that according to surveys that Heidi been doing and others, when you look at who do people trust, that scientists and physicians are still in the top. not completely, but and it's a bit. So there is a capital, to say so, that I think we should use better. But I think we need, training. When I became head of the London School of Hygiene and Tropical Medicine, one of the things I introduced was offer media training to scientists. To, how do when I got in the job, I was appointed for UNH. I was more like a scientist. I would say, what's the problem? It's like an article, introduction, methods, material and methods, and then results, and then the conclusion. By that time, people have already switched off. My first media training was someone who was from CNN, and said, start with the conclusion. And I was resistant. I said, no, you can't do that. You have to explain how you get there. And so I think we need to become perhaps more professional, and then also listen to people. Because, for example, one of the things I've learned from my wife, from Heidi, is that people who are against vaccination and so on and she said, first you need to listen, you need to understand why. Because there may be many reasons. Some people may be because they don't trust government, or they're, politically, or they find a natural way, or some have valid questions about, because no vaccine or no drug has 0 side effects, etc. So but I think we probably, would say, public health departments in all over the world should have very serious budgets in terms of communication, and not like these advertisements. Smoking kills, okay, fine. I just, like in my own country, the ad for smoking that had the most impact was that for young people, and that was kissing a smoker is like licking an ashtray. Disgusting, no? But that had really major impact. And that was then on social media and so on. But that means that we need to think. When I worked a lot in the late 90s and early 2000s with MTV. In these days, for social media, they had 300, 400 million young people between 14 and 22. They made Sugar. It was a kind of a series about Sugar Baby. And they had very sophisticated messages. It was about HIV and gender-based violence. And that was not, you should not do this, or you should wear a condom. Now, it was all, when you didn't know, you wouldn't know the message. But the World Bank did a randomized trial, very interesting, series with the message and one without the message. I wouldn't see the difference. And they found a difference. The people, young people had watched then they used more condoms, there was this and that and so on. So we have to think who we're talking about. But it's easy to say for me because I don't know. I'm powerless also when I'm confronted with people who claim that the earth is flat. How do you deal with that? I don't know. But we need more investment in science, because these people often have massive budgets, and we just like some commercial interest, and we do our best. So that's not reasonable. Yeah, Kevin.
Go on, Kevin. Then we'll get you.
Sure.
Yep.
Thanks, Peter. Kevin Marsh from African Oxford Initiative. Thanks. Several people have talked about reform of the financial institute. What do you think the implications of the coming years are for what reforms are needed for education institutions? You were director of the London School. Many UK institutions, including Oxford, have made major contributions. They've also had major issues, I would say, in the way the interactions with colleagues across the world, particularly in Africa. So what reforms are needed in the way that education institutions approach the new era, and particularly the relationship between education institutions and international funders?
Yeah, thanks, Kevin. This is something that obviously has kept me busy a lot, and I don't have an ideal answer, but I think that there are bits and pieces in there, and know very well, as I mentioned, there are centers of excellence, and how to bring them recognition, full recognition, even, and maybe affiliations and so on. And so I'm a strong believer in partnerships, which are not easy. They're easy on paper, but then, one of the constraints for our universities here is that the overhead, the indirect costs that you get from grants and so on, they are very important for the functioning of the school, and so on. But if in an ideal world, that should also go to the partner institutions. But that could be suicidal for the institutions here. So I don't have an answer to that. That's something I struggled with. And so that's something that funders, I think, should be really. And the fact that the Wellcome still doesn't give a single, zero indirect cost, I mean, that contributes, in a sense, perpetuates the kind of the status quo in this kind of funding. And I hope that one day they will see that. I mean, it doesn't have to be the absurd high indirect cost that you find for American universities, but, like Gates is 15% or so, EU is 25%, and so things that would, because at the end of the day, if the money isn't there, it's all theory, and that I think is one thing. But then also for one of the things, for example, at London School, we had several centers, a center on TB, some on humanitarian things and so on, and that would be co-directed by someone based in a partner institution, country, and someone in London. So that you have a shift in decision making. I think it's probably more a matter of a multitude of smaller steps, but without solving this core support and some funding. I mean, you know it all, but I don't. Yeah, I think that's for me a key issue, and that's where the funders have to come in. Otherwise, I don't see it. Yes, please.
Thank you. My name is
What's for the people on the? Yeah.
Hi, thank you for the talk. My name is Ángel Mauricio. I used to work in the proposal for a national fund for high-cost diseases in Peru. You mentioned that we are aging. It becomes like the non-communicable diseases are increasing. So in the past, we used to focus more on children mortality, mother. It leads to initiatives like the Vaccine Alliance, for example, Gavi. My question is, do you see any space for any kind of these initiatives for non-communicable diseases in order to manage better the risk for example, getting cancer, this kind of new burden of diseases? What do you think about that?
Yeah, to rephrase it, so do we need a global fund to fight diabetes or cardiovascular disease and so on? So I think that there is no space for establishing new global funds, and that's a problem. And many of these chronic conditions, they have to be dealt with in two ways. One, increase that's what we call prevention, I mean keeping people healthy. And the other one is in the health system. And I think there's a lot of innovation that is not being accessible in lower income countries. This is where generic medicines are so important, and but I think that I would expect like a WHO to come up with real strategies, but it's very different from country to country. And as long as there isn't say, more or less universal health coverage, it's very difficult to tackle these chronic issues. In that sense, dealing with infectious diseases is easier. Or we can vaccinate. We can, you have a treatment and then you go home and you're cured, or no. I don't really know, but I think that putting things on the agenda, and when you see, for example, mental health totally ignored and even heavily stigmatized and so on, it's pushing for putting that on the agenda, and I think that is starting to happen, but more in Latin America and in Asia than in sub-Saharan Africa. Because when you take, like in Southeast Asia, I would say diabetes is probably the #1 type of issue at the moment. In the Middle East also, and so on. So there has to be a shift in funding, But I think these are, how to say, there are, of course, this innovation. I mean, the GLP antagonist one, okay, anti-obesity drugs that may prevent many things, but they're so expensive. But soon the patent will be over, there will be generic versions. So that could become then as a real prevention. So, but sorry, I don't have, you had a, yes.
We've got time for
yes.
probably two more questions. Okay, Heather. Yeah.
Hi, my name's Heather Kitt. I'm a paediatrician by training. I'm really interested in what you were saying about the demographic shift that we're seeing in older population and the fact that you think change comes from like a really broad church of people. So I'd really like to hear your thoughts on how we achieved intergenerational equity in that broad church, because I think that if when we don't, that young people feel the brunt of that. We saw that in COVID in this country where young people have like an attainment gap in education, they have higher mental health rates, and they've got, and, you know, in the under fives, stunted development as a result of not being part of that policy discussion. So I'd be interested in hearing your thoughts.
Highly relevant, and what's clear now is that even in a few years after the end, or more or less, of the COVID pandemic, that we still see major consequences, particularly in these age groups. And some spectacular, from increase in suicide, I mean, anorexia, etc. I mean, so many. And here, you know, there are countries like in Uganda or in the Philippines, schools were closed for 2 years, 2 full years. So this intergenerational is a big issue. On the one hand, it's increasingly clear that the health at young age, at children, has a big impact on how you will age, you know. That's the, how to say, that's a very big rationale for the elderly to invest in young people. But I think it goes much further than that, because of this demographic change, at the moment, the pensions of people my age and older are basically paid by young people who work now. But there won't be, on the current demographic evolution, there will be not enough people. Now there are, like, depends on the country, 2 people who work for 1 in Europe, and so soon will be 1, and then less than 1. I mean, that's not sustainable. So there's a lot of issues that we have to think through. It's not only about the older age and longevity, but also about that age. But I think that again, my adagio is always to listen and to look at, you know, in the community, because they're very different in between different communities, even in one particular country, and try to find solution and see whether there is a need to shift resources in there. And the question that I have is also, how long is this kind of post-COVID problem going to last? I mean, I had long COVID, but I'm lucky, it's all over. But it took me 8 months. But then you have this, particularly the mental and social impact. I think that requires far more attention. And there is this parliamentary inquiry, and as far as I know, that it's not addressed by that. And that should be one of their top. So maybe you can write to them, and because they claim that they respond to what's going on in the country.
I'm afraid I'm going to take one last question. I'm going to take it online. And we did a lot online, but I'm going to give you one more difficult question, Peter.
Yeah.
It says, "Dear Peter, how could we, the powerless, contribute to move the center of gravity to reframe how global institutions operate? What can be done to tackle existing and persistent power imbalances?" Respectfully, a global health scholar from the Global South.
Yeah. I think that's by joining forces and lobbying in wherever your own country, that voice is heard in all these global governance and all that, because that's not happening. And make alliances. I think in this room and elsewhere there are enough people who are happy to team up, because if we're isolated and just look at our TikTok or whatever, we're not going to change the world. So it's really joining forces. United, we are strong.
Thanks, Peter.
To quote a famous Caribbean poet, Bob Marley.
It's been a wonderful, and there's so many more questions. I'm afraid we're going to have to invite you back again soon with Heidi, hopefully.
Then Heidi will speak.
I had the privilege of being on the MRC Global Health Advisory Board, which Peter was chairing for 5 or 6 years, and he always came to the point and had incredibly incisive thoughts and comments, and I just thought it'd be wonderful to share that privilege with you. I always remember one thing from Peter. It was actually on Radio 4 one morning, the time when the whole issue of treatment for Ebola was elusive, and there was a big discussion with somebody senior at WHO about what you should do about repurposing drugs. And the person from the WHO said, I don't think we can use these drugs because they have unknown side effects in the context of Ebola. We need a randomized trial. Peter then was interviewed, and he said, in the context of a 100% mortality, I'll take anything. So that's sort of cutting to the chase. So Peter, thanks very much for a wonderful presentation and a wonderful discussion, and we hope we'll have you back very soon.
With pleasure. Thank you very much. Okay. Thank you.